Hi, everyone. Good to see a number of people on the line. Nick, great, you're there. Since we don't have any voting items today, I'm kind of inclined to just get us going. Does that sound good to you? And Nick, is that consistent with your understanding?
Yeah, no voting items, so you don't need a quorum.
Okay, great. That makes it easy. I know we'll have some people trickling in. Sonal actually is in a meeting that she said is running late, so she might be a little bit late, and then we'll have our presenters kind of joining as well. And I believe Phil is planning to join at some point today, but we'll just let folks trickle in while we get started. Awesome. In terms of agenda, I think the rough overview is we have a couple of admin updates. We have panel speakers today, and then we have some of our routine updates towards the end. Thanks for projecting that, Nick. So I'm happy to start with some of the quick admin updates. First of all, welcome. I guess this is officially my first time chairing one of our meetings as co-chair. I was unfortunately not able to attend our January meeting, so really glad to be here today. I know most of you pretty well. Looking forward to today's session. And as I mentioned before, Sana will be joining shortly. So welcome. In terms of updates, we just wanted to give what will be a very quick update on recruitment, and probably doesn't take the whole 5 minutes we allotted on the agenda, just to say that we continue to get more applicants for PHAP. So the job, or the sort of opening announcement that was shared through the county, seems to have been really successful. And at this point, I think we definitely have more applicants than we have positions open. So we're just kind of waiting, which is great news, great position to be in. We're just waiting on the county to go ahead and schedule some of those interviews. My understanding from Nick is that the Board of Supervisors is scheduled to approve new members on March 14th. So hoping we can move through some of these interviews in time to get some recommendations made and hopefully some approval, so that we'll have an expanded PHAB group by April. That's it for me on admin updates. Nick, is there anything you wanted to add?
No, that sounds good. I'll keep you all posted as soon as we get those interviews scheduled, or as soon as the board clerk gets those interviews scheduled. So
excellent. That sounds good. In terms of then the sort of meat of today's meeting, as I think some of you probably recall from our January meeting, the original intent was to have Director Tim Lutz speak to us today about his priorities. He's still new-ish to the county. Unfortunately, he's not able to join us. He and Dr. Kasiri are with the, let me see if I can get the full name here, the County Health Executives Association of California for their legislative visit day. So they're lobbying legislators today on behalf of public health needs and priorities. So we excused them for those purposes. Really exciting. We'll be interested to hear kind of how that went. We've bumped Director Lutz to next month. What that means is that we do have the opportunity actually to kind of continue with some of the themes that we started looking into in our January meeting around street medicine outreach, which is very exciting. So we've scheduled 2 presentations for today. And I guess the last thing I'll say before I actually hand it to Phil to do the full presentation or introduction of our presenters is that this is kind of part of what Sonal and I have spoken about before. In 2023, we really want to kind of go deep on a couple of topics and try out these speaker series, which allows us to like further investigate issues and really understand the landscape on a particular issue. So today, that's street medicine and outreach. Really excited to have 2 meetings in a row on this topic. I know that the January meeting was really participatory, so looking forward to kind of similar energy for today. And then we'll keep an eye on time and maybe give a halfway mark when we want to transition from one speaker to the other. And then we want to leave a good like 20 minutes for discussion. And at the end of the meeting, we will have routine updates from our usual county departments, which as a reminder, we've moved to every other month for now. So that's it for kind of the architecture for today. Over to Phil to introduce our speakers.
Thanks, Libby. Yeah, so as Libby was saying, we wanted to kind of create some continuity and kind of provide a full perspective on the organizations in Sacramento County that are kind of providing this outreach, street medicine, and kind of in looking at the landscape, the other two organizations that kind of rose to the top on our radar were Elica Health, which is one of the really robust FQHCs in the county, and they've had a long-standing street medicine team that has been doing outreach. And then the other is Sacramento Street Medicine, which, full disclosure, I recently became medical director for. So very familiar with their operations, but so we're going to be getting presentations from Tony from Sacramento Street Medicine and Michaela from Elica, kind of on their activities and kind of how they interface with some of the other organizations, and hopefully that'll give us a picture of kind of how the scene of street outreach is operating in our county right now. I don't know who we had scheduled to go first, Tony or Michaela, whichever one of you would like to kick it off. I don't think any particular order is necessary.
Either way is fine with me. Thank you guys for having me here.
Tony, since you spoke up first, do you want to kick it off?
Yeah, let's do it. In full disclosure, I had a tree fall down in my backyard during the storms, and they decided to come cut it down today. So if there's some background noise, I do apologize. Can I get share? Can I share my screen by chance?
And
Or do
while
I
we're
have-
setting
do I have
that
that
up,
for
let
the-
me, sorry to
Sorry.
interrupt. I was just going to say 10 minutes, Tony, for you, and then 10 minutes, Michaela. And I think we'll park all the questions for the 20 minutes after. So
Sounds great.
do you want a time check, Tony, or do you want us to just let you know when we hit 10 minutes?
Yeah, if I could have a time check, maybe at like 7 or 8.
Can do.
I'm gonna do my best. I'm gonna do my best.
Sounds good.
All right. Am I able to?
You should be able to share.
Oh yes, beautiful. All right. Hopefully you guys can you guys see this?
Yes.
Great. Let me. All right. So yeah, my name is Anthony Minacho. Everybody calls me Tony, but I am a family medicine, street medicine, as it were, PA. I practice out of Community Care Health Centers, which is a FQHC out of Davis, West Sac, and Woodland, which is where I practice. And then I also serve as executive director and one of the main providers here at Sacramento Street Medicine, which we started in the summer of 2019, just prior to the pandemic. As far as our mission, we strive, as many do, to provide as quality as care as we can and patient-led medical care to the folks living outside. And our unique advantage here in street medicine is to go where the people are. So we go, along the riverbanks, under bridges, to meet folks where they stay. I'll spare the vision, but the idea is really that street medicine shouldn't have to exist if folks can get the proper care that many of us have. So our current operation, we have 6 different basic and medical outreach teams. We rely on consistent follow-up. Each team goes out to the same camp, same time, every other week. Generally on weekends, we also do some triaging during the week for some of the more complicated cases. We've been doing this for about 2.5 years, almost 3 years now. So we prioritize our relationships and the trust that we've built as the entry point to the care that we provide. And we are all based on harm reduction principles of unconditional positive regard and meeting folks where they're at, honoring people's stories, so that we can, facilitate the care that we're providing. Our team makeup for each of these teams is each team has 2 camp leads. They're either a medical student, PA student, nursing student, or someone with healthcare experience, an EMT, paramedic, so on and so forth. They serve as the liaisons. They're they're developing the relationships. They kind of know where folks are. They have those personal relationships within the camps to allow when the medical team does get there, it kind of facilitates the care, as I was mentioning. We also have a patient navigator on our team, an individual that works with a social work background to help connect the services. One of them being Elka and some of our fellow folks serving the people experiencing homelessness, including Hope Cooperative, SAC Covered, and many of the PCPs and primary care facilities that ideally we can connect to for brick and mortar care. We also have a medical provider, obviously myself and a few others that we've brought on board, and we're in the current state of expanding our capacity with respect to medical providers. Each team also has a medical scribe, so we've trained scribes. We have about 30 scribes that will sign up for each visit. This kind of helps facilitate our ability to expand in terms of medical providers, because there's very little that we have to do with respect to chart. Everything is HIPAA compliant and so forth. We also do basic medical outreach. Our teams, provide the basic survival supplies. And then most importantly, our basic outreach teams serve as an extension of the medical outreach team to see that there's medical needs, if there are any other medical needs that the medical team hasn't addressed. We are currently fully volunteer based. We have about 200 plus volunteers each year. We have medical providers, as I mentioned, medical students, undergraduate students, and the general public. This is just some footage of the stuff that we've been doing. As you can see, we go out into the camps, whether it's under freeways, next to railroad tracks, along the riverbanks. But we go to where the folks stay so that we can kind of help facilitate that care. Our target population is obviously folks that are within Sacramento County, but in a predetermined geographic location. Historically, there are more well-known encampments, larger encampments within Sacramento, and we've kind of worked with our partners to identify what those locations are. And so we go to those locations consistently. And then the main thing for us is that we go to unsheltered folks, not folks that are experiencing homelessness but live in a shelter or have respite care. We have just recently been doing some work in one of the respite centers, but most of our work, I would say 95% of our work is with folks living unsheltered. The person obviously has a medical need that our team can manage within our defined scope of practice. Persons are enrolled on a medical necessity, irrespective of their insurance or ability to pay. And of course, everything's done within collaboration, including the folks here today with Elka. Where we serve, so we serve at the island for folks that are familiar. That's along the American River, just by Chevy's on the river. Loaves and Fishes along Richards Ave, Bassler Road, which is in downtown as well. We used to do Cesar Chavez, but that's been pretty well served within the past 2 years. So we've kind of backed away from there. That's why we're now at 6 X Street, Roseville Road, which is in North Sac, and Morrison, which you can see is kind of in the southern area of Sacramento. In terms of our scope of practice is our current services. We do primary care services. I myself and many of the folks that we brought on have experience in primary care, family medicine, behavioral health, all that good stuff. We've taken care of folks with hypertension, diabetes, COPD, asthma, heart failure. We dispense medications. Ideally, we're dispensing medications on our person. Right now, we're writing prescriptions. We just put in together a process to have PACS teams to be able to dispense medications. We do wound care, harm reduction services like syringe exchange and naloxone distribution with some of our partners. Point of care testing, so diabetes, hemoglobin, random glucose. We do minor procedures, needle decompression, abscesses, so like incision and drainage. We obviously do COVID testing. And then future services, we're working to do on-site STD, STI testing, and through a more recent policy to be able to do diagnostic imaging and lab referrals, as well as specialty referrals and drawing labs in the field. That's all in the process. I think street medicine has kind of come to the forefront of healthcare such that they are now considered direct providers. So they don't necessarily need to touch base with their PCP prior to getting that referral to a specialty specialty care or diagnostic imaging if they so need it. This I think
Tony,
is probably the
just
best.
quickly letting you know you're at your 7-8 minute mark.
Great, sounds good. Yeah, this is probably the best. This is probably what we're most proud of. The people that we serve. We serve 300 folks every 2 weeks. One thing I'm incredibly proud of is the folks that we've trained. We've trained just in the past 2 years. We've trained 400 over 400 undergraduate folks and over 100 healthcare professional students. Anecdotally, we are currently doing research to figure out the actual numbers here, but we've decreased ER visits per year for many of our patients, hospital visits per year, increased connection to brick and mortar PCP, and increase the connection to social services. Again, this is all stuff that's anecdotal currently, but we're currently doing research. And then we were just recently covered by Cap City Cap Radio, which was pretty incredible. Our growth plan. So we definitely want to partner with our folks. There are other folks wanting to do street medicine in the community. Ideally, we'll be moving from the weekend to at least one to possibly 2 full-time teams during the week, multiple days during the week. We want to partner with established street medicine programs around the state, which we're currently doing to provide a path to sustainability. And then obviously we want to expand provider capacity to reach a large number of our folks. The target measures are very similar to the things that I mentioned before, but actually measuring these things, decreasing ER visits, decreasing hospital stays, increasing connection to PCP, establishing referral processes to specialty care, behavioral health, drug use treatment. And as far as in integration and coordination, there's been many folks that are, doing street medicine now here in the city. And I think that, one is we have to understand what the landscape is with all those involved, establish, what may be best with respect to resources, and obviously funding strategies so that we can all be sustainable to care for these folks. And then prioritizing, in my humble opinion, the relationships that we have with our patients, as well with the organizations across organizations as we carry out this care. I think the most positive thing is the fact that the leaders in these organizations are folks that have experience with people experiencing homelessness, and their intentions are good, which I think is really what it boils down to. These are just some of our partners. We have many, many partners that we've been collaborating with and networking with. Keck School of Medicine of USC, we just created a formal partnership. They'll be affiliating with us this year. UC Davis, California North State, Sacramento State, and many of the homeless services that are already doing work. SANE, Hope Cooperative, Sacramento Covered, Sacramento Steps Forward, SAVA, the Sacramento Homeless Union. Many of these clinics that we've kind of touched base with and have either served in or served alongside. It's been incredible. So with that, this is my contact information. If anybody has any questions that aren't going to be answered otherwise, this is my personal email, and this is Sacramento Street Medicine's email.
Awesome. Thanks so much, Tony. So we'll save all the questions for the end, as Libby mentioned. So we'll move on. Michaela, if you're ready, we can kick it right over to you. And thank you so much for being here. Relatively short notice and everything. We really appreciate you making the time.
No worries. Thanks for inviting me. Do I also have share screen access?
Yes, you should.
Looks like it. Looks like it. Okay. So I did also include some of our mobile services in this presentation, and whoa, that didn't work. Try again. Well, are you seeing it in this view? It's being finicky.
Yeah, we can see it in this view.
Okay, I'll just do it in this view then. And move this out of the way.
And Michaela,
Okay.
do you want a time check?
Yes, please. That'd be great.
Okay.
Thank you. I'm going to present for Elica's Wellness Outside Walls, and I'm Michaela Gist. I'm the Associate Medical Director for Mobile and Outreach Services. Just what we'll be going over today. And so here I just want to introduce our mobile and street med team. We are housed underneath a mobile manager. We have one supervisor and then a clinical project coordinator, 3 mobile units, a street medicine team, which you will see is we have vacant slots for animal services, and then our fleet manager staff. Overall, our mission is healing with heart, and then specifically for mobile services, it's to provide services to 2 primary groups, hard to reach populations with barriers to accessing care and underserved students at select schools. And then the idea, of course, is to reduce use of local ER departments and tax-funded services such as fire and police. Our first unit is Health on Wheels. We call them HOWs. HOW 1 is ages 4+ with a focus on peds. We are actually contracted with Twin Rivers and San Juan school districts for well child checks, VSC, vaccines, sports physicals, primary care, and urgent care, but we will accept anybody that comes up, and that often occurs. Point of care testing includes hemoglobin lead, UA, A1C, flu, strep, pregnancy test, COVID, and glucose, multiple different procedures as well. And I'll just kind of move forward from those since we're focusing on our homeless population. Our how-to is currently not running. We're pending contract signing with the Elk Grove school districts, but similar focus as how 1. How 3, we have just 4+, but with an adult focus. We often are stationed at shelters in Sacramento County, and we also bring this bus to different homeless camps that we are able to set up at. So obviously we're not able to set up many locations. This is a big bus to set up. We offer primary care, cryotherapy, pelvic exams,
Oh, I was just gonna tell Michaela that she was breaking
I
up.
was wondering if that was just me.
Yeah, I
too.
think we actually
we're
just
all-
lost her.
All wondering the same. Okay. Maybe we give her a minute or 2, and if she's able to join with connection, we'll continue. And if not, we can do questions for you, Tony.
Sure. I can take one now if we gotta make use of the time. I think George has his hand up.
Yeah, looks like it. Go for it.
Yeah, thanks for that presentation. That was really, I'm really impressed with what you guys are doing. Maybe I missed it. I have 2 questions. Is this funded as a federal qualified? And the second question is, do you guys know about and use Spirit for your the SSVMS Spirit program for your consultations to subspecialists?
I'm very familiar with Spirit. We use them through our FQHC. To answer your first question, we are free. We just got HRSA free and charitable clinic status. So we're not technically funded through as an FQHC. We rely mainly on our grants. We were funded for 2021, 2022 through HealthNet to help provide a pilot program. They re-upped that kind of partnership this year through USC's street medicine team. So there have been a number of street medicine organizations that have kind of popped up recently. And so they selected 4 out of 55 street medicine programs to partner with to provide administrative backbone to be able to do exactly what you're saying, to provide financial stability for sustainability long term. And they chose Sacramento Street Medicine to represent Northern California. So
Is it
we're
possible to directly donate to you from the community? And have you considered a GoFundMe site?
yeah, so we've done some pretty considerable fundraising. We've had several fundraising events in the realm of 15 to 20K on multiple occasions. More recently, because we had the grant through HealthNet, we hadn't sought out another fundraising event, but we certainly will when we need to. And I think there should be one coming up.
Well, I'd love to donate directly to you, so maybe you can put something in the chat.
That would be great. Yeah, we have many folks that do backbone work, administrative stuff, in addition to myself, which is part of the whole process of training leaders. But I'll get that to you if you could put your email in the chat.
I can't because it's locked. All I can do is send something.
Yeah, sorry. Chat is actually disabled under advisement from County Council for compliance with Brown Act. But if you want to send me information through the chat, you can all chat with me. You just can't chat with each other as a board. You can send it to me and I can include that in messaging that goes out after the meeting.
Will Michaela finish?
Yeah, I think we should go back. Michaela, sorry about your connection issues. And if you need to go off video to spare bandwidth, feel free.
Maybe I'll do that. I'm sorry. I'm on a military base. I'm like, the buildings are dead zone, so I'm as close to a window as I possibly can get, and it's awful. Anyways, yes, I will stop my video and keep moving forward.
Okay, great. And I think you were a little bit less than halfway through, so happy to give you another 6-7 minutes, whatever you need, and then we'll open up for questions for everyone.
How are we seeing my PowerPoint again?
There we go.
I think okay, perfect. Okay, so I think I was in the process of going over the procedures that we do on our HAL 3 mobile unit that serves our home sheltered and also unsheltered. So cryotherapy, EKG, nebulizers, ear lavage, pap and pelvic exams, INDs, suture and diabetes foot exam, offering immunizations such as influenza, and we are looking to become BSC certified as well. So our future services that should be coming within the next year or 2 years, we are gathering supplies to get our long-acting reproductive contraception options like Mirena, Kylena, and Nexplanon available. 3 of our providers have taken the MAT training to provide Suboxone treatment. We are in conjunction with UC Davis doing a PrEP grant, and so we are in the process of bringing that service probably in the next 2 years. And then, I already talked about BSC immunizations. And moving on to our street med services. So we took a hiatus for probably about 4 to 6 months or so. The provider that was supposed to was doing that service is no longer and so we have that position open. And as of right now, I am filling that position about once a month. Services are pretty low. We are coordinating with our coordinated access network team. And about 1 month, we'll also bring our veterinary with us, and soon we'll also be bringing a mental health LCSW with us as well. We're doing basic urgent care type visits, including care. We do pregnancy tests, carrying vaccines such as influenza and COVID, and I think that's most of the things. And we just generally go about anywhere. So if we go just driving the streets and seeing what the need is. And then also we've gone out to road as well, as many of the locations that Tony had talked about. This is our street vet. It's run by he is basically here for cats and dogs only. Lots and lots of vaccines though. So he and then the RCP for felines. So there are some multiple places that we are currently collecting with. Lots of and then housing services within the county. So bringing up some challenges and solutions. So the challenge, I think a lot that came up specifically for LCAT organizations was sustainability of our program. And so we're working on to bring more services as you see. But the topic that we're going to be discussing is the Markel Mobile Healthcare Alliance meeting that's happening in March. And this meeting brings all of our mobile services around Northern California together to kind of see what everybody's doing to help see what we could be offering and how to appropriately. Because as many other people probably know, this, at least for us, it's feast or famine with services. As far as patients seeking services, I mean. Patients assigned to other organizations limits our service. So if their health insurance is assigned to Wellspace, Sac County, one community that we can send for urgent care type visits, but we can't send x-rays, we can't send referrals, all of those things get denied by insurance and they have to go back to their assigned primary care provider in order to receive those services. But we do have people on site to help with that change. It's just a phone call to their insurance company to do that. If it works better to see us in mobile or at Elica rather than going to their other assigned. But if that's a conversation to have with the patient, because we want them to be able to continue to come back to whichever organization they so choose, but they do have to choose one. You saw we have some staffing issues. So we do have the jobs posted and just waiting on those. And then a lot of mobile providers in the county are working in silos. So we have brought together a lot of them, including Sac County and Wellspace and actually Molina and others that come together for bi-weekly meetings to discuss what we're doing and where we're going and what resources we can share. We have direct lines to each service. It's similar to a clinic. So we have direct lines and for everybody. I'm going to add my contact information as well as the mobile manager's contact information here. Next, you'll see our Health on Wheels and Street Med calendar is updated on a regular basis online, and it can be accessed at any time. That is it.
Awesome. Thank you so much, Michaela. That was really, really great, really comprehensive. I know Lori, I think you had your hand up earlier. Did you still have a question?
I did. Thank you. I had a couple of questions. So thank you both for your presentations. I'm with Substance Use Prevention and Treatment, so I have a couple of questions for you in terms of any kind of coordination. It sounds like, Michaela, you maybe some of these folks are coordinating with you at this coordination meeting, and Tony, I'm not sure. I think that you and I were connected through Dr. Summers through maybe some email communication around your services. So looking forward to having more conversations around this, but I'm curious if you are partnering at all or you're making any kind of referrals with Crisis Receiving for Behavioral Health Wellspace's program downtown, which is short-term stabilization and referral into withdrawal management and other services, or the county's HEART team, homeless encampment and response teams that are in various locations in the county. I know that they've increased their teams around the Sacramento area. So curious as to if you're having any communications or partnerships with them around your services, and certainly how my unit can partner. I'm curious as to how that can happen in terms of increased communication, referral to our services. I know we have some, resources that may be of assistance to your outreach teams, little pocket cards for behavioral health services and other types of care, Narcan, fentanyl test strips, anything that we could do to support your work. I'm certainly open to that. So just wanted to start with those few questions first.
Yeah, I think it speaks to kind of like, there's so many resources. In fact, we did a needs assessment like 3 years ago, just prior to COVID. And we found like just that there's so many resources. Sacramento is very resource rich, but we're all kind of like serving in silos of sorts. And so it's beautiful to kind of make these connections. I think, we rely on our patient navigators to kind of connect folks into social services. There are people that have, access to maybe folks like you and the HEART teams. We've kind of deferred that because there's so many other resources that we may not be able to directly provide because we just don't have that knowledge yet. But what we do is we connect folks to people like Hope Cooperative, SAC Covered, that are familiar with those types of services. But if we could do a direct thing, that would be incredible. And I would urge whoever might have some, either this or something similar to kind of for us to have a follow-up meeting specifically with our patient navigators, because this is the purpose of that position. I think connection into community resources and services that are there is the reason why we started that patient navigator piece to begin with, because many times the connection into the community and the services that are available is far more important than the actual street medicine that we're providing at that particular time. And so thank you for your work, and I would love to see how we can collaborate and provide better care for our folks.
Okay, thank you. Yeah, I'll be reaching out. So I took down your contact, so I'll reach out again. Thank you.
All right, I think we had Liz Blum next.
I can go after board members, but I'm happy to jump in then. Just a quick question for Michaela. I don't know if I missed it, but how many times a month or typically does your team go out and do street medicine? It seems like you guys have a lot of sort of clinics, but I saw the vans and things. Just curious how often those are deployed out into the community, and if you go specifically to unhoused encampments.
So thank you for your question. Our street med team is currently going out only one day a month in our SCD, but our buses go out 5 days a week. Aside from how 1 and 3 are 5 days a week. And they are often at scheduled locations. How 3 is like I mentioned, they're normally shelter based, but often we will also set up on the side of a road or near encampment if we can get close enough, because there's a lot more resources on the bus, obviously, so if the patients can come from their encampment to a little ways, that's great as well.
Thank you.
Great. I had a couple of questions for Tony. So would love to hear a little bit more about how you have done your site or camp selection. And if you have an estimate of the proportion of the unhoused population that you're reaching. I know that's a dynamic number, but we also just did the point in time count. So curious if you have a ballpark sense of what your organization is able to do kind of as part of the bigger picture. A second set of questions kind of related to the volunteer model. I'm just curious, like if you have staffing constraints, and then you made reference to wanting to think about sustainability, the path to sustainability. So what exactly does that mean for you? Is that strictly in terms of funding? What are some of your sustainability constraints, and what are you focused on in the next, let's say, year or two?
Yeah, so many great questions, and do we have a hard stop at 1? Is that the hard stop?
No, we have 15 minutes planned for discussion.
Okay, great. Yeah, so we've relied on our community partners to kind of identify what folks, at least what encampments are in highest medical need. It's been very fluid. I mean, it's been pretty consistent, but also somewhat fluid in some of our camps, really because of the sweeps. Sometimes we have, 9 patients, and sometimes we have 0 because there's nobody there. So to answer your first question, we've kind of relied on the folks that have done this before us and identified where the medical needs are. And granted, there are always, or at least historically in the past year or 2 years, there are folks that will say, hey, this camp that was at, Morrison Creek and South Sac were displaced, and now they're staying at this location. And so we'll kind of adjust accordingly. As far as patients, it really depends. To your point, it really depends on the location. The island, for example, is a very large camp. And so we could have anywhere between 7 and 13 patients there, which is a relatively long outreach when you think about street medicine. I did street medicine at USC and Skid Row, which there are many, many, many folks that need help. But in many cases, because the cases are so complex, I would see 2 patients in a morning, so, the cases vary, and I wish we had a little bit more time to kind of delve into that piece. But, from any given camp, I would say from 3 to 4 patients to 9, I would say. Times 6. And many times, it's super variable with respect to street medicine. And I think the most important thing is the consistency that you have, because this population is inherently distrustful. And so there may be many, many folks that need the medical care, but just don't trust the people that are there. And so that's why it's hard to kind of, touch base every so often, but not be consistent, because that trust has to be built over time. And that's something that I think we've prioritized from the beginning, where now we're kind of seeing folks that we've seen for years never ask for medical care, now asking for medical care, which is a beautiful thing. But in the grand scheme of things, to your point, it's just a dent in the larger scheme of things, and I think that's why it takes a coordinated effort. As far as volunteer constraints, we have so many volunteers. I think we have 200 or 300 apply. Last time we had our application open, I think 5 or 6 days, we had 250 or 300 applications, and we had to shut it off. So the want to give is there. Where we are now expanding because of capacity, is our provider capacity, because we put in foundations to actually carry out this care, and put in those foundations so that providers can come in and volunteer their time. We're in the process of onboarding 4 or 5 providers that have expressed interest in at least doing 1 visit a month. So it would be 6 visits to camps each month, potentially more. And then sustainability constraints. Yeah, I think that's the biggest thing with street medicine policy. There's been some policy more recently to kind of push street medicine services as a billable service. That's why I feel so excited to work with USC. USC has put in place a mechanism where they can, they were the proponents of this bill, but also they have kind of instituted what a billing system might look like for street medicine. And so they chose, like I mentioned before, they chose 4 programs out of 55, given their expertise, to help do the same for street medicine programs, to provide that sustainability. And we were fortunately and humbly chosen as one of those 4. So this year is going to be great for sustainability. As far as constraints, I work full time. I have 3 little ones, so I only have so much time. I do outreach every week, but the constraints are, one, you have to financially support your administrative backbone so that you can expand efficiently, and then ideally have some type of recurring income so that we're not always having to go back to grantors and for care that folks that really need it. I know billing is the the root of all evil for folks that actually want to provide the care. But yeah, I think it's almost necessary for these folks, and to be able to provide sustainability for the folks that are doing street medicine. So USC is hosting a training next month that'll also kind of touch that, and it'll be here in Sacramento.
Awesome. All right. I have two questions for both of you. Tony, you kind of brought up encampment sweeps are kind of the forcible displacement of encampments. And I'm curious kind of both of your perspectives on kind of the implications that those displacements have on your ability to provide these services and kind of health outcomes more generally. And then the other question is hoping you all could speak a little bit more kind of about the coordination that's occurring and some of the, I think both of you mentioned kind of like working in silos and trying to break those silos. And I'm curious kind of what's coming out of those discussions and what kind of barriers exist there and kind of what the overall kind of dream or goal of that would look like.
Well, as far as when we've experienced the encampment sweeps, sometimes I'll be following up with somebody on a regular basis, and then all of a sudden they're not there, and I have no ability to contact them or find them again unless I randomly find them in another encampment somewhere, or I hear from someone else that they have died or something like that. So it can be really hard to find people when those sweeps happen. Even when I've tried giving our information to them 5 times, it's obviously hard for them to keep in contact. And as far as coordination of care goes, the biweekly meetings that we have with multiple organizations serving unhoused people, we try not to duplicate services in that, like if they're going to a certain location on this week, we're not duplicating services by also going there. Trying to, actually, I was just emailing with Dr. John Landefeld about where they're going this week or next week, and to make sure that we're not going to the same places. We also ensure that we have access to the HEART team, and we have a spreadsheet that we share about different resources that each of us provides or have access to. And then as well as all of our contact information. So if we do have a patient that is Sac counties, I'm able to contact MK or something like that to coordinate that care.
Yeah, and then I can just speak from personal experience and folks that are, we're good friends that were also patients of ours, and like witnessing their tent with all their diabetes medication being taken in front of them and put in a dumpster. I can imagine it's traumatic, but more importantly, it's a detriment to their physical and mental health, and then kind of multiply that on the number of patients in that camp and the many other camps that are swept. I think it would be different if folks had a place to go. I think that's the kicker. But so you can imagine the longitudinal care is kind of gone. The relationships, probably most importantly, is gone, unless you're, like Michaela said, to kind of by happenstance see them again, or many times they come back in the same area. So but there's no telling when that will occur. As far as coordination, we have been doing this work, just doing the good work on the weekends and during the week, triaging folks. I just recently heard of the coordination meetings every 2 weeks, and I think we're going to be added to that. But I think the good thing is that one is we need to just coordinate efforts so that we're not duplicating services, as Michaela said, but also understanding that not any one of us can take on the full load of the folks experiencing homelessness that need medical care, because many of them, whether it's physical or mental health, need services. And so I'm encouraged, because when we first started 2.5 years ago, it was really just Elika, I think, and WellSpace nurses. And So to have the county now and a bunch of folks that are interested in doing this work is promising.
Awesome. Thank you both for that perspective. Lori, do you have another question or comment?
Yeah, more follow-up on like funding and sustainability. Certainly, many of you have heard that counties are receiving some opioid remediation funding, and we're still determining at the Department of Healthcare Services or Health Services levels how we're going to be distributing that funding and what it can look like. But certainly this is an area that has been brought to my attention a couple of times. And although we couldn't fund, the primary care needs, we can certainly fund, behavioral health linkages, both mental health and substance use. I have been in communication with Elika on the expansion of MAT services, specifically Suboxone and buprenorphine, as well as considering ambulatory withdrawal management needs for alcohol use disorder. So there's some communications happening now, but all of these kinds of areas, access to MAT, Narcan, anything substance use related, behavioral health linkages, maybe we can consider assisting your teams with those areas and funding in the future.
Yeah, I think that would be incredible. We are in the process that, this year to making that shift from being solely volunteer to providing financial support and funding to be able to provide, the backbone to expand our services. What's promising is that the DA now is allowing, correct me if I'm wrong, Phil, but providers to not have an X waiver for buprenorphine. And so, two of the providers or three of the providers that we're bringing on have MAT experience in providing MAT services. And I myself am getting trained as well. So, I think part of the issue, as is with many of the health concerns of folks living outside, is actually getting them to the treatment center, getting them connected to the team. So if we could provide that care, like on the first go or the second go, right where they stay, I can imagine the improvement in numbers in terms of reach. So, it would be incredible.
Great. Just picking up on that point, I'm just kind of thinking ahead to our March meeting as PHAB. We're going to have Director Letts back in. It might be nice to just continue this conversation and have him sort of bring in different teams, yours included, Lori, but some of the others, just to speak to how they're thinking about coordination of services and population coverage for some of the different target populations we've talked about today. I think that'd be a nice way to tie it together. So happy to hear if folks have like reactions or specific questions they would want us to prompt Director Letts and his teams to speak about next month, just to kind of tie up this series we've had on street medicine and maybe address some of the holes in our information. So that's a thought for me. People can either shout out now or email me if that's easier. And then wondering if there's any other kind of closing questions or thoughts.
My only other thought to add is kind of just what the Office of Homeless Initiatives, which was like relatively recently established and stuff, kind of what role they're playing, what kind of role the county foresees them play with these types of efforts, and yeah, just maybe bringing them into the conversation as well. So.
Great suggestion. And maybe we can bring them in because of the change in our schedule. We'll have a little bit more speaking time in the March meeting, so we can have them come in as well, which would be neat. Steve?
Just one comment. There has been some discussion about funding, and unless things have changed over the years, all of the people out on the streets are likely eligible for Medi-Cal funding support, and all of them theoretically should be or have been assigned to organizations that are supposedly being paid to provide care. I think there's a lot of money that's out there potentially available to help fund these kinds of operations that is not being appropriated appropriately, I should say. So just keep that in mind, that I'm sure your social workers have told you they're all eligible people for Medi-Cal.
Yeah, I think the issue is finding what is sustainable in terms of a model for billing and rate for folks per patient. Like if you're seeing, it might work if like the working under the same rate of Medi-Cal, Medicare for people experiencing homelessness in the clinic may make sense, but in the streets, the ratio in numbers, it doesn't add up. And so I think the policy that they were trying to push was trying to increase the rate. One is street medicine was never a billable visit, and so that I think is changing or changed. But two, I think what they're pushing is to use it as a bundle to increase the rate to provide that sustainability when you do provide that care. And then secondly, and probably more importantly, is do you have the administrative logistics to be able to bill? Because many of the street medicine organizations aren't necessarily full-fledged FQHCs. They're nonprofits, they're smaller organizations. And so putting that is a larger task than for folks with many resources.
Yeah, and in perspective, we do have the ability to check eligibility for our people, and I would say the majority of them do have insurance through Medi-Cal, and so we have all our Wi-Fi devices and our laptops out there, and our billing for services is just sometimes we see 2 and in a whole day, or sometimes we see none, and so that becomes the hard part.
Yeah. So labor intensive, but high yield to connect these folks that are unsheltered with care, and from a health systems perspective has such potential to prevent future healthcare costs and morbidity and mortality, et cetera. It's just a shame that that's like not reflected in the billing mechanisms that we have currently, but I'm glad y'all are finding ways to navigate it.
Awesome. Taking a look at time, I want to thank you both, Michaela and Tony. That was really great. I said part of a series where we're starting to just understand the landscape a little bit better, and really helpful to hear about what some of your opportunities and challenges are as relates to kind of coordination and sustainability specifically. I was just taking some notes. I'll have to chat with our executive committee and Sanal, the co-chair, about what to build into our March meeting, but would invite you to come back in case we do get Director Lutz to speak about the county's focus on these issues and how they're thinking about coordination and sustainability as well. With that, I think we'll pivot to our routine updates. So Nick, I think we have you up first to give the public health update.
You do, thank you. Yes, as Livy mentioned at the top, Dr. Casserier and Director Lutz are doing some legislative educational visits today, so she sends her regards. I'm going to give a couple of quick updates from Sacramento County Public Health. First, as I'm sure this group is well aware, late in the fall and early winter, there was quite a bit of discussion about the impending triple-demic concerns about COVID-19, RSV, and flu kind of all converging at the same time and wreaking havoc. And I think there's definitely some good news on that front, in that it didn't quite materialize, I think, as was feared. Certainly there were concerns early on because flu and RSV were increasing much earlier than they normally do. Now it is looking like they peaked in early December. And certainly, that was a concern when that was occurring. As if you recall, we look back to January, for instance, of last year, when we had the Omicron surge, kind of in late December and into January. There was concern that if we had something similar to that again, then that would be that would create some issues for sure. So that didn't quite pan out. COVID numbers have looked pretty good. In early December, we did move to CDC community level medium for the county. And that did trigger a few things with CDPH in terms of some requirements for universal masking in certain settings. So that included homeless shelters, emergency shelters, cooling and heating centers, state and local correctional facilities and detention centers. Again, that was a state requirement associated with that CDC community level. Good news, as I mentioned, the COVID numbers, have not been particularly high, certainly compared to last year. And last week we did move back down into CDC community level low, which removes those universal masking requirements in those settings. So all in all, I think some pretty good news there. And related news, and there's been a lot of discussion in the national news the last day or so over the federal government's plans to end the federal state of emergency regarding COVID. And there are plans locally. As you may recall, about 3 months ago, the state announced their plans to end the state emergency at the end of February 28th. And then locally, we announced plans to follow suit and we actually have 2 emergencies locally. There's a state of emergency that is done through the Office of Emergency Services, and there's a public health emergency that Dr. Kassirier issues. And so those will both go before the Board of Supervisors for those to both be rescinded on February 28th for them to ratify that rescission. So plans are for those to end February 28th, and I believe the federal emergency is ending May 11th, I think is what they announced. I think in terms of what that means locally for our response, we started winding down our full response for COVID-19 back in last summer, but have still obviously been working on addressing COVID. Just in terms of information dissemination, we still have a COVID vaccine strike team that does pop-up clinics every week. And I believe that will continue beyond that emergency rescission, but there will be some changes there. I don't have a ton of detail on what the federal implications are, but just from kind of a quick perusal of the news on that, there are some discussions about certainly reimbursement for things like vaccination and COVID tests. Some of those being some of the primary changes that we will see, but probably more to come on that. I think that's all I have for the public health update, but happy to take any questions.
Great. I have a question. I wanted to leave space for others, but I'll just jump in. I think that it's the state level emergency order that allows us to meet remotely as PHAB. And I know that we've been looking into what the implications are, but it's now February, which happened quickly. So I'm wondering if for March we're going to continue to meet remotely, or whether you have any new information you can share about how that applies to the way we function.
Yeah, I actually was just discussing that because I haven't seen any official communications internally from the county about that, but that is my understanding as well. And I'm actually going to ask I don't know, Lori, if you've seen anything specific to impacts of the end of the state order on Brown Act and meetings, since I know you're involved with Alcohol and Drug Advisory Board as well, if there's been any discussion of what that means in terms of ability to continue to meet remotely.
I heard that we were having to return to in-person in March, but I can certainly follow up with our county council around that again. But that was my last notification for our Alcohol and Drug Advisory Board.
Okay.
And that the board members or commission members, you'd have to have a quorum in person in order for votes to occur, that kind of thing. But I'm pretty sure that folks are supposed to be returning in March. But again, I can.
Where will that be? I'm sorry.
And Melinda, I see, is on here. Melinda, if you're listening in, do you have any update on the Brown Act and us returning and County Council's latest guidance to us?
Yeah, we starting in March, well, as of February 28th, AB 2449 kicks in. So you can read that assembly bill to find out what our rules of the road are, but we'll have to meet in person. We can do hybrid. A member, an advisory board member can attend remotely if they have one of 4 excuses, and they actually list the excuses in the law. One is if you're sick, one is if you're taking care of someone who's sick, but it's fairly limited and you'll only be able to do that 2 times in a year. So it's not something you're going to be able to do regularly. We will have to meet in person at a location inside the county that is accessible to the public and posted. And we will have to have a quorum. If you have an excuse, then for that time, you can be counted as part of the quorum and you won't have to post your address, which is the old Brown Act. So it's pretty clear we're going to have to start meeting. So we've been looking and we have found a place to meet starting in March. And most of our committees will be in person. Our committees are standing committees, so they will be in person as well. But we'll be offering a hybrid, well, at least for our general meeting, a hybrid option.
That's the information I received from Rick Heyer. Also, thanks, Melinda. This is Farla Kaufman, past chair. And we were meeting when we were meeting in person for George's information at the county facility, which is on the corner of Stockton and Broadway, just down from UCD Med. So I presume that would also serve as the room in that facility to meet for PHAB and FAB in the coming months, if that's the requirement. I believe there was some investigation about the possibility of having hybrid meetings, but I had not heard anything further. So I guess, Nick, if you check with Rick again, our counsel, he might have an update.
We're going to be meeting at the primary care center, the facility you talked about. It's on the 2nd floor. And my information is they have the capacity for hybrid. So we will be doing, I don't know what it's going to look like though. I think it's going to be somebody's laptop. It's not going to be like being on a Zoom meeting, but we will offer hybrid in that location. And it's a great meeting room.
Perfect. Thanks, Melinda, and thanks, Farla. I think Nixonal and I will just have to take this offline, sort it out, give you more certain information, but I'm glad it's on everybody's radar. It sounds like we're gonna need to plan to meet in person in March, and we'll also communicate when we understand a little bit more about the hybrid option. Any other questions for Nick on the public health updates before we switch, Steve?
It's just to the last point. We used to have to apply well in advance to be able to get that room space over at the public health building. So now's the time to do that.
Great, thanks, Steve.
This is George again. Does that mean we bring our lunch? There's no lunch provided, I presume.
No lunch provided as far as I understand.
Thank you.
Yeah, and we'll communicate more once we get a little bit more information, but glad that it's on the radar. Okay, I think let's switch to the primary health, correctional health update from Noel Vargas. Did we lose? Oh, I know we had him earlier, but it looks like we may have lost him. Okay, let's jump then. Lori, can we tap you for the sub-T update?
Sure. I did prepare a document here. Let me see if I can find it and share it.
I can share it if you want, Lori.
Okay, go ahead. Sorry. Go ahead. Thank you, Nick. So of course, there's lots going on in the substance use world. I always have something to report out. That's the primary adult correctional health one, Nick. There we go. Okay. Just want to start with a fentanyl education awareness update, as well as a methamphetamine education awareness update, our current data that I typically report out at this meeting, but as of the end of last year, we had 150 and maybe a little bit more than that individuals fentanyl related deaths, and that was up from 116 from the year before. So we are continuing to see a rise in this, although we have a lot of prevention, intervention, harm reduction services out there that we're working on and will continue to work on, and we hope to see these numbers decrease here. Part of this fentanyl education awareness campaign effort and our partnership with the Sacramento County District Attorney's Office, we continue with our education and awareness in schools, and most recently into colleges. So we started at Sac State, and we'll move into the community colleges, just providing live assemblies, parent meetings, town halls, things like that. And here's some numbers around some of the work that we did in 2022. So we hit 9 high schools, 1 middle school, 7 parent meetings, a town hall in Elk Grove, 18 school districts, and then most recently a presentation at Sac State last month. We continue our Narcan distribution program through the County of Sacramento. So we have quite a list of county public facing lobbies where Narcan or naloxone is available for anybody coming in requesting it. And we also have provided it to many community-based organizations. Basically, anyone who's asked us for assistance in this, we have a standing order for Narcan. We keep quite a bit of Narcan on hand at our East Parkway location. And so if anybody is in need of Narcan, any organization, any public member that wants Narcan for their family, certainly reach out to me. It's available to anyone who requests it. In addition, we have what is called a Gone Too Soon memorial poster project, and this is through our Sacramento County Opioid Coalition. And so individuals who lost their lives to opioids or fentanyl. We started this memorial poster project, and we use it in all of our fentanyl education awareness campaign efforts in schools and anywhere, any community event. And so we have all these posters of these young people, and actually they span from age 15 to 30s, early 30s. And, we highlight them, we honor them in trying to educate the community around the dangers of fentanyl. And so if any of you know somebody who's lost their lives or want to be a part of this, want more information about this project, the website is there. And you can contact Lauren Werner, who is with the Sacramento Valley Medical Society, and she is the lead on this project. Our methamphetamine education and awareness, here's some local data. Again, back in 2022, 214 deaths. And again, that's a rise from the year before in 2021 at 205 deaths. And we continue all of our efforts, just like opioids, for the methamphetamine concerns and crisis in our community. Our next Meth Coalition meeting is February 9th, and we have a presentation scheduled. And I also included the agenda for Nick to put out to this advisory board. So if you're interested in attending, we have a presentation from UC Davis on meth-induced psychosis versus other psychotic disorders. And then we continuously update our Let's Talk Meth website with resources and information, meeting notifications and things like that. So certainly check that out. This is a trend that I want to start alerting our community to, and many of you know about xylazine or Trink as it's referred to, but I want to start providing more updates around this. We're starting to see this more and more. It's a horse tranquilizer with pain killing and muscle relaxant properties, typically added to fentanyl, heroin, coke, or meth. Big concerns around this because of the overdose deaths we've started to see here in Sacramento. According to our coroner's office, they have seen 10 local xylazine fentanyl involved deaths, and they feel like this is a trend that's going to be increasing. And so we're certainly keeping an eye on this. We're in regular communication around this, and working also with our harm reduction partners out in the community, because we want people to understand that the dangers, again, of xylazine added to all of these illicit street drugs and the consequences of that. So we're also looking to bring a local webinar around this so that we can continue to provide the education and awareness. And so any other harm reduction organizations that may be on this call, or of others, reach out, because we certainly want to get the word out, and we want to learn from those that are doing the frontline work out there in the community as well. We continue our partnerships with our harm reduction partners and SEPTI. We're meeting more regularly now around how to partner, what that looks like in terms of the substance use services and the harm reduction services, and bridging any gaps that we may have had in the future around this. So lots of discussions around information we can provide around overdose risk and Narcan upon people exiting the jail. Again, the mobile medicine information and support, providing Narcan, fentanyl test strips information out there to link to behavioral health services. And of course, around the xylazine danger. And next, just an update on our substance use disorder treatment expansion services. Many of you know that we continue to try to fill our gaps in our current continuum of care around residential treatment, and detox withdrawal management and sober living are areas that we really need to expand upon, and we have lots of funding coming in the next 2 years that will address these particular needs. We have increased our residential bed capacity by 50 last year, which was really helpful in reducing the people waiting for care in our community right now. And so we're continuously seeing those numbers go down, obviously with the goal of treatment on demand. We've never had that here in Sacramento County in over 23 years that I've been with the county, but we are seeing our numbers down, and we hope to have our numbers down to 0 by the summer, so that people can get substance use treatment on demand for all levels of care. So very exciting, and I'll keep you all posted around that. One of the gaps next I want to share is in our treatment services is providing services for our senior and older adult population. So I wanted to provide some data here and maybe future discussion around this. It was just really alarming for me to hear recently. I did a presentation at a local webinar around senior and older adults. And when I pulled the data for Sacramento County, it was just alarming around meth and heroin and fentanyl. So here's some data that I got from the coroner's office in 2021. 17% of the 116 deaths from fentanyl, ages 55 and up, but more importantly, the deaths from methamphetamine. So of the 205 deaths in 2021, 52% of those individuals were above the age of 55. So certainly alarming. And again, around in 2022, 36 deaths from meth, 47% of those age 55 and up. And then just our Sacramento County data, the folks entering our service system, substance of choice are heroin, meth, and certainly alcohol, and then other substance use. So we really want to keep an eye on this. We want to provide services to this population that has historically not received the amount of resources. I think from my unit in I really want to be intentional about seeing what we can do to go to the people. A lot of older adults don't want to leave their homes, due to mobility issues, due to, a fear of, medical providers taking them off of their opioids. Maybe they have pets or whatever their challenges are, but we're looking at ways to maybe go to them and be able to at least provide information about services. And when I've connected to the county's senior and adult services area, when they go out to the homes of senior and older adults, it's usually in an investigative manner. And so it's really hard, they say, for them to share about these kind of sensitive topics, but it's really important because we're seeing the impact to this population that we want to be able to bring the services to them. And just lastly, I will give an OD mapping project update at our next meeting when I'm able to report out. And again, we're getting that opioid remediation funding coming to our county. And I hope to hear from many of you and other boards and commissions around where you think this money can be well spent moving forward. Since we will be receiving this funding for 18 years, it's real exciting that at least my unit in the Department of Health Services will have opportunities to fund opioid related activities. Thank you.
If I can chime in with a quick question. So regarding the residential bed capacity and stuff, I just want to applaud you all for the work you've done on that. Like that is definitely seen and felt in my world, and seeing a lot of people get into residential treatment in a much more rapid fashion. So thank you for that. One aspect of that that I assume is on your radar is kind of benzodiazepine dependence and the demand for kind of medically supervised detox. I'm seeing a lot of people who are physically dependent on benzodiazepines, which is a really serious and life-threatening withdrawal syndrome that can include seizures. A lot of the benzos that are on the street right now are laced with fentanyl, xylazine, et cetera. So they are a particularly high risk group and seem like they tend to skew kind of younger. And I'm seeing a lot of those folks that are kind of seeking treatment, and they're kind of between a rock and a hard place because they can't get into most residential places because they don't have the degree of medical supervision that's required for their withdrawal syndrome. And there's not really any outpatient treatment available and stuff. And so I don't know, it's a really tough problem. And so I'm just curious if you all have been kind of discussing that and thinking about ways to kind of increase these medically supervised detox capacities.
Yeah, thank you for that comment. It's certainly detox withdrawal management is a gap in our service system, and we have, limited amount of bed availability right now. However, we do have a promising couple of agencies interested in a property where we would increase the withdrawal management bed capacity for medically managed situations like this. And so it is on our radar, it is on our horizon, and the majority of the people actually currently on our current wait list do require medically managed detox. And I think once we get a couple of these providers on board, we're going to see a huge shift in those numbers going down. So thank you, Dr. Summers. Yes, we are aware of it, and we're certainly hopeful. I'm thinking in the next 6 months to address some of these needs.
Awesome. That's super exciting. Thank you for that.
It is.
Keep me posted.
I will.
Great. I was wondering, Lori, if you were able to share, it was really surprising to see the data on older adults and senior adults. Do you have other data that you're able to share in terms of how the deaths that you presented break down, whether it's by housed, unhoused, age bracket, anything else that can help us understand sort of like who are the folks that are impacted and how that relates to your sort of responses and your strategies?
Yeah, not from the coroner, unfortunately. I get very limited data from them, but through our county system, I can certainly break that down a little bit more in a future meeting.
Great. I think that, yeah, that'd be really helpful to see, just to understand. And then my second question was around the opioid remediation funding. Sort of what are your decision-making timelines for determining how those funds will be dispersed?
Yeah, we haven't really determined that yet. So the funding approval has to go through our Board of Supervisors still, and I believe that's due to be heard in March. And then some of this funding will go out to a competitive bid process, but we are just kind of putting the conversation out there, requesting proposals from individuals just around what they think the needs are in the community to address opioids. And I've received a lot, and we certainly want to continue to fund some of the things we have in place, like the fentanyl education and awareness, and some of the other prevention and harm reduction strategies that we're currently implementing. We want to expand those, but have new things that these dollars go toward that we may not be addressing. But I'll keep you posted on the timelines. I just don't really have that right now until it's approved by our board.
Great. That makes sense. I mean, I think you've heard us say before, we're trying to pick kind of 3 or 4 topics to go deep on this year. And some of that is taking the themes that came out of our PHAB retreat last year, where Dr. Kasiri presented. And there was a lot of discussion around diseases of despair and substance use and harm reduction. And so we're thinking about that as a theme. We want to hear from Director Lutz next month. But if that ends up being something we go deep on, this feels like a good practical way for us to partner to explore the topic and be a thought partner for you on how to appropriately distribute that funding. So just putting that thought out there, and I think we need to hear from Director Lutz first and then organize ourselves internally, but moving in that direction. So if you have any ideas too on how we can be helpful as PHAB, feel free to email Samel and I.
I will. Thank you.
Great. Any other questions or comments for Lori? Okay, unfortunately, we seem to have lost our correctional health colleagues. So we'll bump that to next time. I think then that takes us to public comment and then we can close. Is there any public comment today that we haven't covered already? Liz?
Yes, hi everyone. Liz Blum here. I'm on the Health Services Coordinating Council, and I wanted to let you all know that we have our meeting on February 9th, and that if you don't know already, the Health Services Coordinating Council is meant to be sort of the hub of health related advisory boards in the county. And I wanted to flag it especially because Tim Lutz will be presenting at that meeting, and so I know he'll be coming to you all next month, but just thought it might interest you all to attend our meeting next week, and yeah, you're invited.
Great, maybe we can get that info from you, Liz, and circulate through Nick. And it reminds me that I think we have an empty position on that committee, so that's something we should put on the agenda for March. Steve, I think you're saying something.
2 positions.
We have,
Well, we used to be 2. Maybe it's down to 1. I may be wrong.
okay, well, we'll investigate. I think that'd be a nice coordinate. Yeah. Awesome, Jessica?
Hi, thanks for having me. Jessica Sankis. I'm also with the Human Services Coordinating Council, and it is 2 positions. We have 2 positions per advisory body, representing 6 advisory bodies. And yeah, if you have any questions, yeah, please feel free to reach out to Liz or I. We can send an email to you, Libby, or to Sanal to share with everyone.
Awesome, thanks, Jessica. And we're getting hopefully an influx of new members in the next few months, so it'll be great to keep in mind sort of who might want to play that kind of role, but hopefully we can get that filled over the next few months. We'll definitely ping you if we have questions.
Thank you. Yeah, I did see that go out in the county newsletter. I saw that and was like, I'm going to take a page out of your book next time we have vacancies to fill. That was really great. Really good idea.
It has definitely helped. We've got a lot of applicants, so highly recommend. Awesome. Any other public comment question? I think you guys are public today. Okay. Awesome. Well, thanks everybody. Appreciate it. We have a couple of action items on our side, and it sounds like we might be seeing each other in person in a month, which is exciting. As always, if you have questions or feedback, feel free to email Sanal and I, and hopefully we'll be communicating to you guys soon. Thanks, Nick, as always, for organizing us, and thanks, Lori, for the routine updates, and Nick as well.
Sounds like we have some homework.
Yeah, we do.
Have a
All
good
right,
day,
thanks,
everyone.
guys. Bye.